Thank you for joining my lecture, which I'm calling Face-to-Face with Body Dysmorphic Disorder. We're going to start talking about a variety of things today. First, we're going to talk about what is body dysmorphic disorder. We're also going to talk about BDD misconceptions and myths. We're going to talk about how to identify and diagnose body dysmorphic disorder. We'll talk about treatment modalities as well as the trauma conceptualization model. So these are some of the things we'll be talking about during today's lecture. So what is this that we call body dysmorphic disorder? What is BDD? I'll use the terms BDD and body dysmorphic disorder interchangeably. So what is body dysmorphic disorder? So BDD, individuals with BDD have a misperception about how they look. They have a misperception that a body part or parts are defective, misshapen, deformed, or ugly. This is their misperception. To those of us on the outside, right, we believe it's a misperception. To the individual with BDD, this is what they experience. So again, there's a misperception in how they feel they appear, but that is, to us on the outside, it's a misperception. To the individual suffering from BDD, this is what they actually see. Individuals with BDD have obsessive thoughts. They have negative, intrusive thoughts about what they perceive is defective in their appearance. They also experience intense emotions. Shame. Shame is one of the root emotions that individuals with BDD experience. It's one of the root emotions behind this disorder. Individuals with BDD also experience dysphoria. They have disgust, especially around the body area that they believe is so ugly or defective. There's also anxiety. Now, I want to make clear, BDD is not an anxiety disorder. However, individuals with BDD do have anxiety, often out of the fear that they will be shamed or they'll be found out. And there's also the emotion of loneliness. And BDD is a very, very lonely disorder. So loneliness is definitely one of the main emotions we also see with individuals with body dysmorphic disorder. Individuals with BDD do compulsions. What are compulsions? These are behavioral rituals they use in an attempt to minimize the intrusive thoughts and negative emotions that they have around what they consider their body image defects. So some of the main themes we're going to see with body dysmorphic disorder is misperception and how they look, obsessive thoughts, intense emotions, and compulsive ritualistic behaviors. There's not too much in the DSM-5 about body dysmorphic disorder, but some of the criteria you will see in DSM-5 is the following: a preoccupation with one or more perceived defects in appearance, repetitive behaviors that are performed in response to the appearance concerns, significant distress or impairment, again, associated with what the individual perceives as defective. And the appearance preoccupation is not better explained by concerns with body fat or weight in an individual whose symptoms meets criteria for an eating disorder. So I want to make clear, body dysmorphic disorder is not an eating disorder. These are separate entities. They're separate diagnoses. So these are some of the criteria you will see in DSM-5 about BDD. In body dysmorphic disorder, any body part can be the focus of attention. The body area that we see most individuals BDD are concerned of is their skin. 73% of individuals with BDD are concerned about their facial skin. It could be concerns their skin is too light, too dark, too red, too spotty. They could have concerns their pores are too big. They could be concerned that they have acne scars or all the above. But the most common BDD body area that we see in the BDD population is concerns about facial skin. This is followed by hair concerns. 56% of individuals with BDD have concerns about their hair. It could be they're concerned about the texture or color of their hair. It could be about perceived hair thinning or concerned about hair loss. But it's not always just about the hair itself. A lot of times the hair concerns are about how the hair looks in contrast to their face and how their face looks in contrast to their hair. So the hair concerns in body dysmorphic disorder can be about just the hair. It can also be about how the hair looks in relation to the face or both. 37% of individuals with BDD have concerns that something is wrong with their nose. It could be they feel their nose is too small. They could feel their nose is too large. They could feel there's something wrong with their profile. They could think their nose is too crooked or bumpy. But that's the third most common body area of concern we see with individuals with BDD. 22% of individuals with BDD have concerns that something looks wrong about their stomach. 20% of individuals with BDD have concerns about their eyes, and another 20% believe something is wrong with how their teeth look. 6% of individuals with BDD are concerned about their jaw. This could be anything from thinking their jaw line is not defined enough, feeling their jaw sticks out too much, their jaw doesn't stick out enough. So this is another concern we see frequently as well. Again, any body area can be the focus of attention with individuals with BDD, but in general, the face and head, so from the neck up, are the areas of concern that we see with the vast majority of individuals with BDD. Now, why is this? And there could be a couple reasons for this. For one, in Western culture, we do not cover our face with clothes. So the face is exposed, whereas we can hide or camouflage our bodies from the neck down because we wear clothes. Now, it's true an individual could wear a hat, and individuals with BDD do wear hats to hide their hair or maybe shade their face, but it's very difficult to hide one's face. So this could be one explanation why we see the vast majority of individuals with BDD are concerned with areas of their appearance from the neck up. Another reason might be this, that when we speak to someone like I'm speaking to you right now, we speak to their eyes, we speak to their mouth, we speak to their face. I don't speak to your knee, I don't speak to your feet, I don't speak to your elbow, I speak to your face. And as I'll talk about later, individuals with BDD have a lot of themes and issues around intimacy and human connection. And we connect at the face when we talk to someone. So this could be another explanation of why so many individuals with BDD have concerns about areas of their appearance from the neck up. There's something called muscle dysmorphia. We see it mostly in males, and it's concern about not being big enough or muscular enough. This isn't BDD per se. It's a variation of BDD, and it's a cousin of BDD, but not BDD per se. But again, it's when an individual thinks they're not muscular enough or that they're not big enough. One of the main points I would like you to get out of this lecture is that BDD is a severe psychiatric disorder. BDD is absolutely not vanity. In fact, it's the antithesis of vanity. Individuals with BDD just want to look normal, So this is not vanity. It's not someone being self-conscious either. It's a severe psychiatric condition. And if we look at some of these statistics, this will back what I just said. There's a lifetime suicide attempt rate of 25%. So 1 in 4 individuals with BDD will attempt suicide at least once in their life. And this is higher than we see in major depression or bipolar disorder, and as high as we see in schizophrenia. There's a 30 times higher completion suicide rate with individuals with BDD than in the general population. And if this statistic doesn't speak for itself, what will? BDD is a severe psychiatric disorder and needs to be treated as such. Almost half of individuals with BDD will be hospitalized in a psychiatric facility at one point in their life. And 27 to 39% of individuals with BDD are delusional in their beliefs. So if we look at these statistics, these facts, BDD should not be taken lightly. It's a very severe psychiatric condition, and it's not just someone who's self-conscious or doesn't like an area of how they look. I think to some degree, the term has now been marginalized. There's become a pop psychology term in the media when people call it body dysmorphia, which in itself is not a diagnosis. It's called body dysmorphic disorder. And it's become, people use this term when they don't like an area of their appearance or they're overly concerned or self-conscious. That's not what we're talking about. Body dysmorphic disorder is a severe psychiatric condition that incapacitates people. I want to talk about some misconceptions and myths about BDD, and there's quite a few of them. One of them is it's only a disorder of Western countries. That is not the case. There's another myth that BDD is a female disorder, and that also is not the case. Another misconception is that BDD is a disorder of the affluent. BDD occurs on the whole socioeconomic continuum. Another myth is that BDD is a disorder of younger people. This is not true. And another myth is that BDD is a disorder of Caucasian individuals, and we see BDD occurring in people of all racial and ethnic backgrounds. So looking at some of these myths, BDD does exist worldwide. BDD has been diagnosed in both Western and non-Western countries, including Italy, Pakistan, Germany, Turkey, the United Kingdom, in the United States, as well as in Africa, Asia, and South America. So BDD has been diagnosed worldwide. The prevalence, age of onset, the number of body parts, and BDD behaviors are generally similar wherever BDD is diagnosed in the world. Now, cultural and ethnic factors may influence what specific physical features the BDD sufferer is preoccupied with. There is no evidence that culture, ethnicity, race is an etiology behind BDD, but culture and ethnic backgrounds may determine what area of the body the individual is preoccupied with. So by no means is BDD only a Western disorder. It exists worldwide. BDD is prevalent. It's thought between 0.7% upwards of 3% of community samples have BDD. So about 3% of people in the world have BDD. That's a prevalent disorder. That's a lot of people. So BDD is not rare. It's not uncommon, but it's often misdiagnosed or underdiagnosed, and we'll talk about that a little later in this lecture. 45% of individuals with BDD are male, and 55% of individuals with BDD are female. So this is definitely not exclusively a female disorder. Here at the Los Angeles Body Dysmorphic Disorder Clinic, we always see at least 50% male. So there's a lot of men that have body dysmorphic disorder. It's not just a disorder of women. 2 to upwards of 13% of university students suffer from BDD. So obviously, university students can be considered younger people, but BDD exists on the whole age continuum. I've worked with individuals in their 40s, 50s, even early 60s with body dysmorphic disorder. And I've had quite a few clients with BDD tell me they remember their BDD symptoms starting as early as age 4. So BDD exists on the entire age continuum. It's not just a disorder of younger individuals. 3 to 5% of general psychiatry patients, possibly a body dysmorphic disorder. 6 to 16% of cosmetic surgery patients possibly have BDD. Now, just because someone gets a cosmetic procedure does not mean they have body dysmorphic disorder. And there's quite a few individuals with BDD who do not get cosmetic procedures. So I want to make those points clear. But it's thought that upwards of 16% of cosmetic surgery patients probably have body dysmorphic disorder. 9 to 15% of dermatology patients have BDD. Now, looking at the statistic I mentioned before, that 73% of individuals with BDD are concerned with their facial skin, I wouldn't be surprised if the number here, 15% of dermatology patients, is actually a lot higher than that, considering how many BDD patients are concerned about their facial skin. But no individual with BDD who goes in for dermatology treatment is going to tell a dermatologist they have BDD. And there's many other reasons why it won't be diagnosed, but I wouldn't be surprised if that number is a lot higher in dermatological settings. So again, BDD is a very common disorder, very prevalent. It's thought of upwards of 3% of the world has it. If we look at the bottom statistic here, 53.6% of amateur bodybuilders could have this. Now again, that would be more of the muscle dysmorphia variant, right? It's not BDD per se, but in the amateur bodybuilding population, upwards of 54% of individuals definitely have body image disturbances. Now, only 15% of individuals with BDD share their body image concerns with their mental health providers. So with individuals with body dysmorphic disorder in mental health settings, only 15% share their concerns. That means 85% of these individuals with BDD are not talking about it, even with the confidentiality that comes with a mental health setting. So how is that? Why is that they're not talking about it? There's a variety of reasons. One reason is individuals with BDD do not want to be seen as vain, and they are definitely not vain. They are absolutely the opposite of vanity. They're tormented by what they feel is wrong in their appearance. So they don't want to be perceived as vain. That's one reason they won't bring it up. There's so much shame at the root of BDD. Individuals have so much shame, and they don't want to draw attention to the body part. So a lot of times they will not even bring it up to their mental health provider because of the shame, or it might take a long time to do so. So there's shame, there's embarrassment, and there's often limited insight. So many individuals with BDD lack insight into their symptoms. They might end up in treatment because of other diagnoses. But to the individual who lacks insight, they don't think they have BDD. They think something is really wrong with their appearance. So they're assuming the mental health provider sees they're ugly or the body part is defective. And so they're thinking, well, why would I even bring it up? It's obvious it's defective. So the limited insight, along with the shame and embarrassment, is another reason why BDD is often underdiagnosed, misdiagnosed, or not diagnosed at all. Unfortunately, BDD sometimes is only detected once there's been a suicide attempt or suicide completion and a note is left. It's not uncommon that there's severe substance abuse with individuals with BDD, and sometimes they end up in substance abuse treatment settings, and that's where they're diagnosed. Another reason why individuals who work, or clinicians who work in settings with substance abuse should really screen for BDD. Upwards of 50% of individuals with BDD have a history of substance abuse. Multiple cosmetic procedures could be a red flag that there's BDD, but not necessarily. So it's worth looking at, but again, not everybody with BDD gets cosmetic procedures. So these are some of the reasons why BDD is often misdiagnosed, underdiagnosed, or just not diagnosed at all. So if only 15% of individuals with BDD talk about it to their mental health providers, how do you discern it's BDD? How do you find out it's BDD? So here are some questions that I'd recommend you ask to the individual that you're treating. Are you concerned about areas of your appearance, especially from the neck up? Now, if an individual with BDD is sitting in front of you, they could say yes, but there's also a possibility they're not ready to talk about it. So there is a chance they'll say no. But if you have a trusting, good relationship and rapport with your client, it's a good possibility they'll bring that up. If they say yes, you might want to ask the question, do you spend at least 1 hour a day thinking about the area of your appearance that you think is defective? It doesn't have to be an hour. It could be 45 minutes. It could be all day long. But I think it starts giving you an idea of how preoccupied they are with what they believe is defective in their appearance. Another question you might want to ask, do you frequently study the facial or body features of other people and compare these to what you don't like about yourself? This is called a BDD compulsion. In my experience, the vast majority of individuals with BDD do this. They're constantly studying what they don't like about themselves with other people to kind of gauge how their body part looks, if it's wrong, if it's ugly, if it's misshapen. So this is a question I would recommend you ask as well. Another question you can ask, do these concerns interfere with functioning, such as with work, school, or relationships? This gives you an idea. How much is this impacting the individual's life? You know, are they not going out? Are they not going to class? Are they not going to work because of it? So it gives you a better idea of how intense the BDD symptoms may be. Other questions. Do you avoid doing anything because of these concerns? Individuals with BDD are avoidant. They tend to avoid a lot of things, especially interpersonally. Find out about what they're avoiding and if it's connected with what they feel is defective in their appearance. Are there any behaviors that you do in response to these concerns, such as checking the mirror, touching the body parts that you consider are defective, etc.? These are called BDD compulsions or rituals that they do in an attempt to ward off the negative thoughts and negative emotions. And so I would ask about this too, and it can give you an idea of how many of their behaviors are based around what they really perceive as defective in how they look. Do your concerns make you feel ashamed, depressed, anxious, or even disgusted? Very valid question, just to get a better idea of the emotions they're experiencing surrounding what they believe is defective. And do you study photographs of yourself or compare these images with past photos of you? Now, individuals with BDD, these are not the individuals taking photos and constantly putting up the images on Instagram. Those are probably narcissists. Individuals with BDD are not going to be posting their images on social media. If they do take the photos, they're looking at the body area that they feel is defective. That is a BDD compulsion. And or this is frequent too. What they're doing is they're taking the picture and they're comparing it to a past picture to see if there's been change in the body image area that they believe is defective. So that's a question I would definitely ask. Do you study photographs of yourself and or compare these images with past photographs of you? Definitely could be a sign that there's a body image disturbance or BDD going on here. A while ago in Health magazine, in this particular issue, Sarah Michelle Gellar came out and said the following: "Oh God, I'm a female. I totally have body dysmorphic disorder. I think most women do." And there's many inaccuracies in this statement. First of all, BDD, as we talked about before, is not a female disorder. It's almost 50-50 male-female. Well, 45% male, 55% female, but it's not just a female disorder. Also, individuals with BDD don't talk about BDD, especially if they're untreated. They don't want to draw attention to the body area they think is defective. And most individuals with BDD, even if they acknowledge they have BDD, are ashamed of the diagnosis. So I always question, if someone comes out in the media and talks about having BDD, I always question, is it really BDD? Because that doesn't fit the BDD profile. So, again, there's quite a few inaccuracies in this statement. And I think it's another way of kind of discerning if BDD is really going on or not, because individuals with BDD don't brag about it, they don't talk about it, and they definitely don't want to come out and talk about the body area or the diagnosis in public. So how might we conceptualize body dysmorphic disorder? So body dysmorphic disorder, there's crossover between BDD and obsessive compulsive disorder. With both of these disorders, there are negative intrusive thoughts that the individual can't get rid of. Now, BDD and OCD are definitely different disorders. In my opinion, there's many more differences between the two disorders than similarities, and treatment between BDD and OCD are definitely different. But there is crossover, and again, the crossover has to do with the negative intrusive thoughts that both disorders have. With anorexia nervosa and BDD, the similarity in the crossover is both diagnoses have deficits in visual processing, how they perceive the areas of their body that they feel are defective. So there is a crossover there. And with social anxiety disorder, social phobia, and BDD, there is that crossover too in terms of anxiety around interpersonal interactions and feeling that one is going to be judged. So there are crossovers with BDD and these other disorders, but I want to make sure it's clarified that BDD in itself is its own separate entity. So when working with BDD, you have to expect comorbidity, and that's the norm. If we look at some of these stats here, 11 to 13% of individuals with BDD have social anxiety disorder. Something I always ask when working with my BDD clients is your social anxiety disorder directly linked to how you feel you look or what you're preoccupied is wrong with your appearance? Is it a separate social anxiety disorder based on how you're going to be judged and how you interact with people, or is it both? In my experience, there's a much higher incidence of social anxiety with the body dysmorphic disorder population than 13%. But it's something I always screen for, and I always ask these questions. Is the social anxiety directly linked to the BDD or separate of the BDD, or both? 8 to 37% of individuals with BDD have obsessive compulsive disorder. 14 to 42% of individuals with BDD have major depression. Something I always ask my BDD clients: is your major depression directly linked to how you feel you look, so linked to your BDD, Or do you feel you have a separate major depression or separate dysthymia, or both? In my experience, individuals that I work with BDD, many more have incidents of major depression than 42%. Many do, especially when they start treatment. And something I try to discern is, where is the depression coming from? Is it not linked to the BDD? Is it directly linked to the BDD, or both? And I think it's important to really discern what is what there. 41% of individuals with BDD have a history of polysubstance abuse or dependence. You know, substance abuse is common with individuals with BDD. And when you think about it, if you are tormented and can never stop thinking about how you look all day, every day, it's not surprising that individuals will self-medicate. As you probably already know, it's really difficult to do treatment for any diagnosis, including BDD, unless someone is clean and sober. So prior to coming into treatment, or at least simultaneously, substance abuse issues have to be addressed when treating body dysmorphic disorder. There's something called ORS, olfactory reference syndrome. And with this syndrome, it's when individuals feel that they're giving off, emitting a body odor or a smell that's offending other people. I kind of call it the smell version of BDD. There's not that much information out there on it. I used to think it was very rare until I started screening my BDD clients for it. And what I found is, I would ask my BDD clients, you know, are you ever concerned that you're giving off a body odor that's offending other people? And it's not uncommon that I get a yes. I do have this experience, and I've never been asked this question before, and I never brought it up because I assumed that you smelled me and then I smelled bad. So it might be a good idea to screen for ORS. And in my experience, olfactory reference syndrome often is based in shame as well. So we're going to see a lot of comorbidity with BDD. That is the norm. Personality disorders are very prevalent when working with body dysmorphic disorder. In one study, 148 subjects with BDD, 57% had one or more personality disorders, the most common being avoidant personality disorder, followed by dependent personality disorder. And I would agree with this. The vast majority of individuals I work with either have full-blown avoidant personality disorder or have avoidant personality traits. And it kind of goes with the disorder when you think about it. I mean, these individuals really think something is deformed or ugly with how they look, so they avoid people and things. There's another study of 17 BDD subjects which found 100% personality disorders. I guess this was the case in the study. Not all individuals with BDD have personality disorders, but it's not uncommon that you will see personality disorders in the BDD population. There was another study done of 17 subjects with BDD. 87% had at least one personality disorder, cluster C being the most common. And cluster C is the avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. So I would say, yes, cluster C is probably the most common cluster of personality disorders we see with BDD, but most commonly avoidant personality disorder or traits. So don't be surprised when working with a BDD client that there'll be a lot of comorbidity along with personality disorders. Here's a hypothetical model of body dysmorphic disorder. And I want to start with the red oval here. So the vast majorities of individuals with BDD have this belief that somehow they're fundamentally or inherently defective. That is going to be a theme that you're going to see with the BDD population. Obviously, if you fundamentally feel inferior or defective, you could have low self-esteem. We know the essence of BDD is such that you're focused and hyper-focused and overvalued importance placed on appearance. So, of course, it's not a coincidence that the individual is going to go to their body looking for defects and have low self-esteem connected with that. You're going to see perfectionism. You're going to see perfectionism with individuals with a lot of shame and who feel fundamentally defective. And this can go over to the body area, where since there is overvaluation on their body, trying to make their body perfect to compensate for low self-esteem and fundamentally feeling defective. Individuals with BDD are self-conscious. They have social anxiety. And, you know, this is no surprise. It's connected with feeling like they're less than other people. Individuals with BDD have Abnormalities in visual processing. This has been shown in fMRI and PET scans that individuals with BDD, in essence, miss the forest through the trees. So someone without BDD, when they look at their face, they see everything. They see the whole picture. But when an individual with BDD looks at their face, they hyper-focus on details while missing the big picture of their face. And then because with BDD, there's obsessive thoughts and compulsive behaviors, their thought process is such that they get caught and stuck on this body part they believe is defective, and then they start doing these compulsive behaviors to try to rid themselves of these thoughts and feelings. Individuals with BDD also have misinterpretation of facial expressions. And we also see this with social anxiety. So someone without body dysmorphic disorder, if they see someone with a neutral look on their face, they'll interpret the look as neutral. But someone with body dysmorphic disorder, when they see a face with a neutral look on it, they will interpret it as negative. So individuals with BDD are interpreting neutral facial expressions as negative. And this is just going to fit into the self-consciousness, the feelings of inferiority, the low self-esteem. So there's a lot of complex moving parts going on with body dysmorphic disorder. And as I always say, BDD is an amalgamation of a lot of things going on, and we have to be alert of all these moving parts going on when diagnosing and treating body dysmorphic disorder. So what do we do with BDD? What do we do? What are some of the therapeutic approaches for body dysmorphic disorder? Psychotherapies. Let me talk a little bit about psychotherapies, and then I'll get into depth about them. So you're going to hear a lot in the research about cognitive behavioral therapy. We'll talk a little more about that later. Something I utilize a lot when treating BDD is interpersonal therapy, specifically around attachment theory. Family systems therapy. It's not uncommon that BDD starts within the family system, so family systems therapy can be very valuable in the process of BDD recovery. Insight-oriented therapy. Now, I want to emphasize, I do not think the entirety of treatment for BDD should be based in insight-oriented therapy. However, I think it's very important to get an extensive history of the individual's BDD and family history. No one just wakes up one day with BDD. Now, individuals with BDD will remember a point in time their BDD started, but once you explore it further, you'll see that their BDD started long before that. So there definitely can be some insight work. It can be very important, but I wouldn't base entire treatment just around insight-oriented work. Group therapy. There's not a lot of BDD groups that exist. What I say about BDD groups are this: the individual needs to have been in individual therapy for a while before they start the group process. Why is that? If you start an individual in a BDD group too early, what's going to happen is they're going to walk in the group. To them, everyone else looks normal, and they're going to be thinking, oh, wait, those other people have BDD, but it's me who's actually ugly. So in my opinion, it's contraindicated to start someone in a BDD group until they have some really good individual therapy time under their belt, because it often backfires. Because if they don't have good insight and they haven't had sufficient treatment yet, and they enter a BDD group, they're going to interpret it as, I'm on the outside, I'm not a part of. Everyone else looks normal, they have BDD, but I'm the ugly one. Exposure and response prevention, ERP. Now, this is an integral part of BDD therapy, but it's how you do it and when you do it, and I'll talk more about that a little later in this lecture. Pharmacotherapy is important as well, and I'll be talking about that soon. I want to make the point, though, flexibility is imperative. BDD is a very, very rigid disorder. It's very inflexible. You as a clinician, if you try to treat BDD in a very cookie-cutter, rigid way, you will become stuck very quickly, and in essence, you will be mimicking the BDD. One treatment modality does not fit all. So I always say people with BDD present with very similar symptoms, but how they got to those symptoms differs. So you have to find out who you're working with to really know what direction you need to go in while treating that individual. You need to be flexible. If you're not, BDD will win that battle. So flexibility as the clinician is the key when working with such a rigid body image disturbance as BDD. Therapists beware. It is very easy for a clinician, a mental health provider, to become distracted by the patient's obsession about the body area that they believe is defective, and you need to be mindful of this. So the individual, assuming that they've spoken to you about their body image disturbance, they are likely really convinced that the body part's the problem, and you can't invalidate that. You need to validate that. But you also have to be very careful of mimicking BDD and only focusing on the body part. And when that individual starts treatment with you, that's what they're going to focus on, because to them, that's the problem. But if you only focus on the body part as well and not look at the bigger picture, in essence, you're mimicking, including with BDD. So definitely don't invalidate the concerns. You want to validate their preoccupation, that they believe something's wrong with their appearance, but you also have to look at the bigger picture as well. So we do not want the process of therapy to mimic the theme of BDD, which is the inability to stop obsessing about an area of the body. And we don't want to chase body image symptoms. It doesn't work. As we talked about before, it's not uncommon that an individual with BDD is concerned with multiple body parts. They might be concerned with their skin, their nose, their hair, one area more than other areas. So that's not unusual either, that they have multiple areas that they believe are deformed, defective, or ugly. If you start chasing symptoms, there will be no end to it. So again, you need to validate their experience, that to them, they really are having this experience, something's wrong with their appearance. But as a clinician, if you chase symptoms, you will actually be participating in the BDD itself. So the therapist does not want to collude with the BDD symptoms. So if we treat BDD symptoms as the central theme, you as a therapist may unintentionally be conveying that the body part is the central issue. So similarly to the other points I just made, to the individual with BDD, yes, their body area is utmost important, and it determines who they are and how they live. And they see it as defective and ugly. But as the clinician, you cannot over participate in that. If you make the body area the epicenter of treatment, you are conveying the message that's the problem. And again, you'll be colluding with BDD. You have to look at the bigger picture. And as I said before, that's why as a clinician, you have to be very flexible when treating BDD. Otherwise, you'll be mimicking BDD with the profound inflexibility we see with this disorder. Regardless, as a clinician, you won't win the battle of BDD head on. So even if you start chasing symptoms, BDD will always win. So we know on the outside, so the client with BDD really believes the body part's the problem. But on the outside, we know there's a lot of things going on internally. And if you only chase symptoms and look at symptoms, you will never win that battle. And again, you'll be actually mimicking the BDD and to some degree participating in the body dysmorphic disorder. Another statistic which is important to know, 50% of BDD patients have what we call overvalued ideation. Now, what is overvalued ideation? Overvalued ideation is not quite delusional, but it's on the border of delusional. So it's very severe BDD. And these individuals, one day you might be working with them and they're absolutely convinced it's the body part that's the problem. The next time you see them, they might be like, well, there may be BDD going on, but I also think I'm really ugly or deformed. So it fluctuates. You'll see individuals with overvalued ideation. It can fluctuate their belief system, but it's on the border of delusional. And so some treatment considerations here. If half of these individuals with BDD have overvalued ideation, they're more likely to have poor insight or maybe delusional, and are usually more depressed than BDD patients without overvalued ideation. And they are also less likely to stay or seek or stay in treatment. So if the individual if they lack insight and they don't think it's BDD, well, why would they stay in treatment? Often they won't seek treatment, and it's not unusual that individuals with poor insight, either their family members contact me or will reach out to you or a significant other, because they themselves may just be convinced it's the body part that's the problem and it's not an emotional or psychiatric disorder. So you need to take this into consideration when treating BDD, looking at, their insight. Is there insight, or is there overvalued ideation or delusional belief system going on? So here are some common themes that we see underneath the BDD facade. And again, this may take a while to get to in the therapy process, because the individual with BDD will come in and be very preoccupied with which they believe is the problem, which is an aspect of their appearance. You got to see themes. Individuals with BDD have a lot of ambivalence or fear around intimacy. I always say you can't treat body dysmorphic disorder without looking at interpersonal relationships. They go hand in hand. You can't treat one without the other. Individuals with BDD have difficulty with trust, especially in interpersonal relationships. It's going to be a theme that you're going to see in the BDD population, and it's something, as a mental health practitioner, you need to look at. I wouldn't bring these up right away, especially if the individual has very poor insight, because if you bring these up too early, they'll interpret it as you're invalidating their concerns or don't believe them. But I would keep this in mind, that this is most probably going on under the surface. And individuals with BDD have difficulty with attachment. Many have disorganized or insecure attachments from infancy or childhood. And so that's a thing you're going to see, difficulty with attachment. Something I always say is that BDD individuals have attached. They've attached to a body part rather than a human being. They've attached to a body part rather than a human being. Many individuals with BDD are stuck. A very common theme you're going to see. They're stuck in psychosocial stages of development that are not equivalent to their chronological age. And often this is in adolescence. You'll find individuals with BDD tend to be quite intelligent, very analytical, and emotionally shut down. And chronologically, they're one age, but often they're emotionally stuck at an earlier age in their life. And part of the therapy process for BDD is getting them unstuck so that their emotional age can catch up with their chronological age. There are often parallels between the BDD patient being stuck, obsessing about a body part, and being stuck in their capacity to move forward in life. Something you're going to hear very frequently from individuals with BDD is, if I only could fix my body part, then I can move on with my life. And you're going to hear this a lot, and they believe it. They need to fix or change the body part, and they blame the body part for everything. If this only looked different, I can move on with their life. On the outside, we know a lot more is going on, and we have to look at that. But we see these parallels between them being preoccupied and stuck on body part, but they're also stuck in life as well. So treatment for BDD also involves organized attachment. The individual with BDD has already attached, and as I said before, the problem is they're attached to an inanimate object, the body part, rather than to a human being. They're having a relationship with a body part, and by definition, if you're having a relationship with a body part, there's so much less room for connecting to a person. And the body part becomes a safe object that the BDD patient attempts to control and fix. So as much as they're tormented by the area of their body that they feel is defective, it becomes the object they attach to. And again, it disconnects them from people, because they're having relationships with a body part and there's less room for human beings. And it's difficult to formulate relationships with people when one is having a relationship with a body part. And again, I would not bring this up early in treatment. This observation is something you might want to talk about later. I think if you bring this up too early, especially with individuals who have delusional or overvalued ideation BDD, they will interpret it as you're just another person who doesn't believe them or who is invalidating them. So some of these points I want you just to keep in mind, but I would not bring them up too early, because they probably won't agree. The individual might not see it, and they might also experience it as you invalidating how they perceive their appearance. Behavioral therapy is an important part of BDD treatment. There has to be some behavioral therapy in the BDD process. Where I start with behavioral therapy is working on and looking at a reduction in BDD compulsions. BDD compulsions fuel the intrusive thoughts and in turn, the intrusive negative emotions about their appearance. And then this is not theory. This has been proven many times over, that compulsive ritualistic behaviors actually make BDD worse, make the negative intrusive thoughts worse. So I think you need to start by working with the client to identify many of the ritualistic behaviors they're doing around their body and to gradually start reducing these behaviors. So behavioral therapy does not begin with exposure and response prevention. With the BDD population, if you start exposure and response prevention too soon, many of them will be out the door. They can't tolerate it. It's way too early. That's for down the road. So I start with, well, first and foremost, you need to build self-efficacy. You need to help the client build self-efficacy, and you need to allow them to choose to reduce their BDD compulsions. So I would start by making a list with them about all the compulsions they're doing around their body. There's probably many compulsions they don't even know they're doing because it's become so normal to them. And then maybe very gradually start having them make the choice to start reducing some of these BDD compulsions. And in a little bit, we'll talk about what some of these compulsions may be. So there has to be a reduction of body-related compulsions because these contribute, because if the body image compulsions are decreased, that'll also contribute to a decrease in intrusive negative thoughts about the body. And another point I like to make about this too is individuals with BDD regulate their emotions by doing these body-related rituals. So in the process of reducing the BDD compulsions, it also helps them learn to regulate emotions without utilizing external objects such as body parts. And this in itself helps contribute to integration of self. So the reduction of BDD compulsions not only helps reduce the negative intrusive thoughts about their appearance, it also is a beginning of them learning how to regulate emotions internally rather than just through their body. So there's many, many, many different BDD compulsions. Here are some of the ones that are common and that you might want to look at and that the client may want to start working on reducing. A decrease in reflective surface checking. It can be anything. It doesn't have to be just mirrors. It can be reflective surfaces in car windows, storefronts, on someone's computer or their cell phone. It can be anything that's a reflective surface that the individual's checking to see if the body part's defective. So there has to be a decrease in checking reflective surfaces. There has to be a reduction in touching compulsions. A very common BDD compulsion is the individual touches the body part that they believe is defective. So there has to be a reduction in touching compulsions. There should be a reduction in camouflaging behaviors. Camouflaging behaviors could be so many things. It could be wearing excessive makeup. It could be wearing sunglasses. It could be facial hair to hide what they think is wrong with their skin. It could be hats. But a gradual process of decreasing these camouflaging behaviors. Reduction of comparing or scrutinizing oneself to others. Now, this is a hard one because if someone walks in front of you, you're going to see that person in front of you. But that's very different from if someone walks in front of you and you start studying their nose, their hair, their teeth, their skin. So this is a hard one, but you need to bring to the BDD client's attention that when they start studying a person's physical features, they are doing a BDD compulsion. It's also not good when you're interacting with that person, because if you're having a conversation with someone and you're studying their face, then you're disconnecting. So at least bring this to the client's attention that comparing and scrutinizing compulsions is just that. It's a BDD ritual and it needs to be decreased. Some other BDD compulsions that need to be decreased. So there has to be a reduction in the amount of time the individual spends on the internet searching for cosmetic solutions or looking for reassurance. Now, as I stated before, not everybody with BDD has had or gets cosmetic procedures, but many do. And the internet's a safe place to do research. That is a BDD compulsion, so there needs to be a reduction in that. And there needs to be a reduction in taking photos of themselves. As I said previously, these are not the individuals who are taking photos of themselves and putting them all over social media. When individuals with BDD take pictures of themselves, they're doing so, only they will see the picture and they're studying what they believe is wrong with their appearance. So this definitely is a compulsion and needs to be decreased. there has to be a reduction in reassurance-seeking compulsions. Now, many individuals won't talk about the area that they believe is defective at all because of the extensive shame. However, some individuals with BDD will ask maybe their significant other or a family member, does this body part look ugly? Does it look defective, or what have you? And it puts the individual who they're asking in a very difficult position. And it is a compulsion. The individual who is being asked this question wants to help the person suffering, but here's the problem. If they answer, then they're actually colluding with the BDD compulsion. If they don't answer, they feel guilty that the individual with BDD asking them is feeling bad. So they're put in a very, very difficult position. I tell my clients with BDD, it's ultimately your responsibility to not do reassurance-seeking compulsions because you're putting that other person in a very difficult position, and it's also not good for the relationship. So reassurance-seeking compulsions have to be decreased. Also, there needs to be a reduction in avoidance behavior or safety behaviors. BDDers are avoidant individuals. They avoid a lot of things, not just interpersonal interactions. And I'd start with very peripheral things that are avoiding, maybe not direct interpersonal interactions, but there has to be some reduction in some of these avoidant behaviors. So this is just naming a few of BDD compulsions, but this is where I would start behaviorally. Just this gradual process of the client outside of the office making a point of trying to reduce some of these BDD rituals. Now, cognitive behavioral therapy can help reduce overt body image obsessions, but CBT alone is rarely sufficient by itself when treating body dysmorphic disorder. I'll be the first to say that behavioral therapy is an important part of treating BDD. However, I'll also be the first to say it's insufficient to treat BDD with just behavioral therapy itself. You have to look at each individual, although their symptoms may present very similarly, how they got there is different. So we will be doing behavioral therapy, but you have to look at other modalities, especially the interpersonal ones. There's a lot of themes going on around difficulties with intimacy and interpersonal relationships. Those have to be addressed in therapy. Now, when you get to a place in BDD treatment where there is ERP, exposure and ritual prevention, it's also called exposure and response prevention, you want these exercises to have to involve people. Again, you don't want to start ERP therapy early on. You want to really build a rapport with your patient. You don't want to start it too early. The first behavioral therapy you want to start is just the reduction of BDD compulsions. But down the road, when you get to ERP therapy, it occurs later in therapy, because the patient has to first attach to you and feel safe with you before they attempt to attach to others. So I like the ERP exercises to be interpersonal, involving people, but make sure your client feels safe with you before you start these exercises with other people. So exposure exercises for BDD entail activities that increase interpersonal contact. So it's good in multiple ways. One, ERP has been proven to help reduce overt BDD symptoms, but why not at the same time really start the process of helping the BDD sufferer connect with people? Continuing with ERP exercises, BDD exposures can involve the body part, but it has to involve context of people. So of course, when interacting with people, they're going to be concerned about the area they think is defective, but at least it's in context with other people. And like most exposure exercises, these should be done very gradually and begin with a therapist rather than unfamiliar people. So I'm all for the interpersonal interactions and people when doing exposure and response prevention exercises. However, start with your client one-on-one. Make sure they're comfortable with you before you move outside of the office with unfamiliar people. And something I want to remind all of you is that when you do exposure exercises, it's not just the exposure exercise. The response prevention afterwards is imperative. You can do the best exposure exercises in the world, but if your client leaves your session and goes right to the mirror, not only are they undermining the work you just did, they're actually making BDD worse. So you have to educate them and remind your BDD clients, it's not just the exposure exercise, it's what they do a couple hours afterwards, not doing compulsions, which is equally, if not more important than the exposures themselves. Now, medication management, specifically the serotonin reuptake inhibitors, is an important part and first line of BDD treatment. So it's been proven multiple times that SRIs are first line for BDD treatment, especially achieving a higher dose. And this often can take 10, 12, even 16 weeks to get to true efficacy. This has been shown in controlled studies and open label studies that serotonin reuptake inhibitors are valuable when treating BDD. There's been multiple case studies in children, adolescents, and adults who have BDD that's shown and demonstrated a good positive response when taking SRIs. And what's interesting too is with individuals without delusional BDD and individuals with delusional BDD, what's interesting is serotonin reuptake inhibitors, the SRIs, do seem to help even those individuals with overvalue ideation or delusional beliefs. So insight can improve, it can definitely be improved with SRIs, and this in turn can help in the treatment process because obviously if they have more insight, they can further engage in the BDD treatment. So definitely medication management is often an important part of the BDD recovery process. There are treatments that I definitely do not recommend when treating BDD. So I can't recommend cosmetic procedures. BDD symptoms usually exacerbate after a dermatological or cosmetic procedure. What I don't do is I don't tell a client not to get a cosmetic procedure. Why? Well, if you tell any human being not to do something, they will do it. And also what I find way back when, if I told a BDD client not to do it, they would go on a vacation for a month, and they knew that I knew that they knew that I knew that they were getting a cosmetic procedure, but they were too ashamed to talk about it, and they wouldn't. And it's often after the cosmetic procedures that their BDD symptoms will flare, and they'll need you to communicate and will need your help. So what I tell a BDD client is this: look, I hear that that you want to get a cosmetic or dermatological procedure. I'm not going to tell you not to. If you would like my recommendation, I'd say give BDD therapy a try for a year, and then you can circle around to the cosmetic solution. Give it a chance. But if you do decide to get a cosmetic procedure, I'm not going to judge you. I'll just let you know I'm here for you because you may need to talk to me after you get the procedure. So I just leave it open and non-judgmental. But cosmetic procedures don't work because even the most precise cosmetic surgeon, they're treating a body part, they're not working on the emotional or psychiatric components. And very, very, very rarely is the individual ever happy with the outcome of the cosmetic procedure. And in the very rare occasions they are, it just jumps to another body part. So cannot recommend cosmetic procedures for treating BDD. Something else I do not recommend when treating BDD is utilizing the mirror for exposure and response prevention. I do not recommend this, and I'll tell you why. If you do put a patient in a mirror to do exposure response prevention, you're conveying the message that the body part must be the problem. To the individual with untreated BDD, it's the problem. We don't want to convey that message. We don't want to be part of BDD. So making your exposure exercises about the mirror is basically saying the body part's the problem. It's not the problem. It's what they perceive as the problem. It's all the underlying and psychiatric and psychological and emotional material that's the issue. So that's one reason I don't recommend mirror exposures. Another reason is you'll probably be participating in a BDD compulsion with them. So quite a few individuals with BDD study what they don't like about themselves in the mirror. So you might think that you're doing a BDD exposure with them when they're participating in a BDD compulsion. So for both these reasons, I do not recommend you do exposure exercises using the mirror. Rather than using the mirror, go to people. We ultimately want the individual with BDD to connect with people. Make exposure exercise is having to do with interpersonal relationships. The trauma conceptualization model with body dysmorphic disorder. So BDD per se is not necessarily synonymous with trauma. BDD has many different etiologies: genetics, family system, repetitive reinforcing behaviors. However, it's not unusual that somewhere on the BDD individual's life timeline, they have had and experienced trauma within an interpersonal context. So some individuals with BDD have had capital T traumas, not all have, but it's not unusual that somewhere on their life continuum, there has been some trauma within the context of interpersonal relationships. And this needs to be looked at in BDD treatment and recovery. Something I always say, I look at developmental trauma, which is also known as emotional developmental neglect. So it's not always what did happen, rather what did not happen. And no client comes into treatment talking about what didn't happen because they don't know what didn't happen. But it's not uncommon that individuals come from backgrounds where there was a deficit in what I call the nutrient of nurture. We need food, water, and shelter to survive. But without nurture, the nutrient of nurture, we can't thrive. And it's not unusual with BDD clients. They come from backgrounds where they didn't get nurture, and there's definitely developmental trauma. And as a clinician, you need to be aware of this because it won't be given to you. You might look at the capital T overt traumas that are reported, but they can't report what they didn't get because they don't know. And some of the themes of the deficits of nurture, we're going to see insufficient emotional mirroring. The irony is so many BDD sufferers get stuck in the mirror looking for something. The irony is many did not get sufficient emotional mirroring from primary caregivers or earlier in their life. We're going to see histories of emotional misattunement. There's often insecure, anxious, or disorganized attachments, and overall deficits in nurture. So again, it's not always what did happen, but it's very common with BDD patients that you're going to see what didn't happen. And they're searching for this profound, deep, lonely, empty feeling that they have through concrete body parts. The body becomes a conduit for them experiencing the world. And it's not uncommon that individuals with BDD, when they feel lonely, they interpret that as, oh, I feel lonely because something's wrong with how I look. Actually, often they feel lonely because they didn't receive sufficient nurture earlier in their life. One other thing I want to say about trauma and BDD is, in my opinion, when individuals with BDD get cosmetic or dermatological procedures, in my opinion, it's not uncommon that they are actually being re-traumatized. And I think this is one of the reasons, why I don't recommend cosmetic procedures for individuals with BDD, but often I think it explains why we often see an exacerbation in symptoms of BDD after a cosmetic or dermatological procedure, because they're actually experiencing a re-traumatization. So you definitely need to look at traumas, what did and what didn't happen when treating BDD. So here are some resources that you might be able to utilize with body dysmorphic disorder. My book is called Face to Face with Body Dysmorphic Disorder, Psychotherapy and Clinical Insights. It's written to everybody. It's written to mental health practitioners, to family members, and to sufferers. Here's the book, Face to Face with Body Dysmorphic Disorder. It's in many public libraries, and you can also get it on Amazon.com. And again, it's not just written to mental health providers, it's written to family members as well as BDD sufferers. You can visit our website, the Los Angeles Body Dysmorphic Disorder and Body Image Clinic website. That's www.bddclinic.com. I'd highly recommend The Broken Mirror by Dr. Catherine Phillips. She was the first person to write a book on BDD, The Broken Mirror. The first one came out in 1996, and it's been revised since, but I definitely recommend The Broken Mirror by Dr. Catherine Phillips. And also, you might want to look at the website of the UCLA Eating Disorder and Body Dysmorphic Research Program. They do a lot of, obviously, brain scans and research regarding BDD and other body image disturbances. So here's some resources that you can utilize. At this time, I will take some of your questions. One question we have is, how can we change ourselves or the language we use with ourselves, our kids, siblings, to be more supportive of a healthier attitude towards our and their bodies? Well, I mean, I think it starts with self-awareness. I mean, I think if a parent has a body image disturbance that is untreated, their child will overtly or covertly, pick up this message. So I think it starts at home. I think it starts with parenting. Something I hear a lot is, oh, I live here, thus I live in Los Angeles, thus of course I'm going to have a body image disturbance. And that isn't the case. Everybody's exposed to the same messages, but not everybody gets a body image disturbance or BDD. And what I see is that people who come from backgrounds where there's sufficient enough nurture and unconditional love are just less vulnerable to BDD and body image disturbances compared to individuals who don't get the basic nurture they need. So I think it definitely starts at home. Let me see some other questions here. So here's another question. Let's say you have a client who's very focused on one or various parts of their body in relation to their weight, but do not necessarily meet eating disorder criteria or engage in disordered eating behaviors. Would this be a type of BDD? It could be. It's a very good question. I think a starting point is screening out if it's an eating disorder or not. As I said before, the majority of individuals with BDD are concerned from the neck up, but there are individuals with BDD who have concerns about areas from the neck down. So I think if you rule out eating disorders, disordered eating, etc., it could very well be BDD. I've worked with individuals who have concern about their wrists, their ankles, their elbows, their thighs. So again, the vast majority of individuals have a concern from the neck up, but it can be from the neck down, and treatment would be like we've talked about in this lecture. Here's another question. What if the client's BDD is about a body part that could be perceived as deformed or atypical, and they have a more pronounced nose and others would agree? Okay, so, many people have body parts that don't fit in maybe the generic norm. It starts to become a body image disturbance when their identity, their sense of self, their complete values are based around this body part. There are people that don't have a perfect nose, don't have perfect cheekbones, don't have the perfect jawline, but don't have BDD or a body image disturbance. So it becomes a body image disturbance when they have these intrusive negative thoughts about the body part. It impacts their life. When they can't, when their identity is so infused with this, that's when it becomes a body image disturbance. But just because a body part isn't quote unquote normal or perfect doesn't mean it can't be BDD. So here's another question. Is body dysmorphic disorder permanent? Can someone recover from or eliminate BDD through treatment, or is it something that simply has to be managed? People with BDD absolutely can get better. I always tell people up front when they start treatment, if you're curious, motivated, and interested in getting better, you can. People don't have to suffer with BDD their entire life. Now, with any disorder, I don't think we're curing it, but people with BDD absolutely can get better and have a higher quality of life, including intimate and quality interpersonal relationships. Now, maybe down the road, when they're under stress, there's a lot of change in their life, interpersonal stress. Yeah, maybe BDD symptoms will flare, but at that time, they'll have the skills, the tools, and the insight to better handle it, and the episode won't last as long. So yes, people absolutely can get better from BDD. I see it all day. I see it all the time. There's a lot of work to do. It's a long-term process. It's a lot of work. But if the client is motivated, interested, and curious in getting better, they will. All right, that seems to be all the questions. Thank you very much for joining me. I hope this has been helpful, and I hope it allows you to better diagnose and treat clients with body dysmorphic disorder. There is hope. Individuals with BDD can and do get better. Thank you for joining me today. Have a very good rest of your day.